talk today is on the management of acute scaphoid. I'm an active member of the British Society for Surgery of the Hand and the current president, and also of the European Federation, but I have no commercial interests to declare. I would like to acknowledge the contributions of Greg Giddens, Tim Davis and Joe Dias to the contents of this talk. As a part of my role in FESH, I was in Budapest in Hungary when Russian troops moved into Ukraine, a member of FESH, and I watched with horror as the events unfolded. To help and support our colleagues in Ukraine, we're running a weekly open access webinar on the challenges of the acute management and reconstruction of injuries from conflict, starting on Thursday, the 24th of March. So, scaphoid injuries are not particularly common. What is all the fuss about? Well, scaphoid fractures have a bad reputation, as these quotes from the literature illustrate. I'll try to address two questions today. How should we treat a patient with a normal X-ray? And when should we operate on an acute fracture? So the scaphoid is the most commonly injured carpal bone and represents about 2% of all fractures. The incidence in the UK is about 12 per 100,000 per year. It's more common in areas of social deprivation, and the majority are male, 7 times more common in men than women, with an average age of 22. Scaphoid fractures can be classified according to the site. Around 2/3 of fractures are in the waist, and about 1/3 of these fractures are displaced. The proximal pole of the scaphoid is covered with cartilage and therefore has a rather tenuous blood supply. Clinical examination is reasonably reliable, with 9 out of 10 acute fractures demonstrating tenderness in the snuff box. Lindsay Muir's group from Manchester have confirmed this using MRI as the gold standard and have shown that ASB tenderness on its own is more accurate than any combination of physical signs. What about X-ray? Around 1 in 6 waist fractures cannot be seen on the first X-ray. A full scaphoid series must be obtained. Traditional management of patients with a suspected fracture but normal X-ray has been to splint and re-examine at 2 weeks. However, examination at this stage seems to be hardly more accurate than a coin toss. 2-week X-rays are not a lot better, with only 2 out of 3 fractures being visible. Does it really matter? Well, some fractures that cannot be seen on X-ray do go on to a non-union. This series of X-rays from a recent publication shows progression from an occult fracture to advanced arthritis over 30 years. In this example of mine, I cannot see a fracture on X-ray, but there's clearly a waist fracture on MRI. MRI is more reliable than a CT scan. It also allows assessment of the soft tissues. MRI will also show other injuries that may be present. So, on to the second question. How should acute scaphoid fractures be treated? In a cast or with fixation? The differential thread on modern implants allows compression of the fracture, achieving a very stable construct. Many are also cannulated to allow ease of insertion. So if we start with distal pole fractures, almost all will unite, and these can be managed with a short period in a splint. A complex trans-scaphoid perilunate injury like this is very unstable, and it must be reduced, and the scaphoid should be fixed as early as possible. A dorsal approach allows simultaneous ligament repair and scaphoid fixation, which will help to restore stability to the injury. Proximal pole fractures, and for this I mean fractures in the proximal 20% of the scaphoid, are relatively uncommon. They represent only around 6% of all scaphoid fractures, but they have high non-union rates. And even if they do unite in plaster, they take a long time to unite, and I would therefore recommend early fixation. They should be fixed through a dorsal approach. The approach is in the interval between EPL and ECRL, as shown here. The site of the fracture in the bone has a pronounced effect upon union rates, with non-union almost unheard of in distal pole fractures, rare in undisplaced waist fractures, but quite common in proximal pole fractures. A delay in presentation and treatment also leads to a marked increase in the rate of non-union, and I'd recommend fixation in waist fractures which present late, so after about 2 weeks. It's also worth remembering that some acute presentations are in fact old, unrecognized non-union, such as in this example. So, here's a slightly displaced scaphoid waist fracture in a young man. Who would fix this fracture? If you would fix it, why would you fix it? Is it the risk of non-union? To correct malunion and prevent deformity, or to allow an earlier return to work? Scaphoid non-union does lead to wrist arthritis, and this risk is much reduced if the fracture unites. There is no need to immobilize the thumb in a scaphoid cast. It's been clearly shown that there is no advantage in this randomized controlled trial. So I would submit that most scaphoid waist fractures should be treated, at least initially, in a plaster, as the majority of displaced scaphoid fractures will heal in a cast. This does fly in the face of a recent trend towards acute fixation of scaphoid fractures. Here I've pulled the data, a large number of older series of scaphoid fractures, and you'll see here that 93% of fractures, scaphoid waist fractures, will heal in a cast. You can criticize these studies as union was diagnosed with a plain X-ray rather than CT, and there was no differentiation between displaced and undisplaced fractures. However, we know that approximately a third of these scaphoid waist fractures are likely to have been displaced. There are 2 studies which report the results for displaced and undisplaced fractures separately. They found that 88% of displaced fractures healed in a cast. Tim Davis has done a series of studies which have shown that the assessment of displacement on plain X-ray is unreliable, and he's recommended CT scan. He also found there was a very high incidence of non-union in fractures that are displaced by 3 millimeters or more. The SWIFT trial led by Professor Joe Dias, has recently been published. 439 acute scaphoid waist fractures with 2 millimeters of displacement or less were randomized to treatment in plaster or with a cast. You'll note that almost 40% of these fractures are displaced by between 1 and 2 millimeters on the initial CT scan. Half of these were randomized to treatment in a cast and the other half to acute fixation. After 6 weeks, a CT scan was obtained for all those treated in a cast. 90% of the patients showed evidence of bone union. The other 19 patients crossed over to internal fixation. The CT scan was repeated at 1 year, and this showed that 97% of patients treated surgically and 94% of patients treated in a cast went on to sound bone healing. Union was defined as bone bridging over greater than 20% of the fracture. None of these have gone on to non-union at 5-year review. So you could argue that non-union rates are lower with surgery. But I would argue that this actually shows that over 90% of patients did not need an operation. What about return to work? Well, on average, the surgery patients returned to work within 3 weeks. But so did the patients treated with a plaster. And what about deformity? Well, rather disappointingly, there was no difference in deformity between the two groups on the 52-week CT scan. The complication rate in the plaster group was very low, although 19 or 9% of the patients received surgery within the first year. The surgery group had a much higher complication rate, with a very high risk of screw penetration on CT scan. In those with less than 2 millimeters of protrusion, the screw may well have been buried under the cartilage, but 1 in every 6 patients had penetration of more than 2 millimeters. And 1 patient in the screw fixation group developed such severe chondrolysis that they went on to a 4-corner fusion within the first year. This is an example where the screw length looks fine on the PA view, but if you look at the lateral, it's actually protruding dorsally. And the reason for this is that the entry point is too volar, meaning the screw does not line the central axis of the scaphoid. A recent study has emphasized the importance of oblique views to assess screw length. So, would you still have this fracture fixed if it was you? My take-home messages are that 1 in 6 scaphoid fractures are not seen on the initial X-ray, and I would recommend an MRI scan if there is reasonable grounds to suspect a scaphoid fracture. Distal pole fractures should be treated in a simple splint for 3 to 4 weeks, do not require a cast, and do not require surgery. Proximal pole fractures and complex scaphoid fractures associated with carpal dislocation should have early fixation. Waist fractures displaced by 3 millimeters or more, or where there is delayed presentation, should also be considered for fixation. But an acute waist fracture displaced by 2 millimeters or less should be treated in plaster for 6 to 8 weeks. And a CT scan should be used to assess healing if there is any doubt. And this will mean that 10% of these patients go on to internal fixation. Be very careful to avoid screw penetration.